4, 3, 2, 1. We are live, sir.
Yeah, thank you. It's Ikon. Really good evening, one and all. Today's this virtual meeting of API-ICP postgraduate training program. Today is special day for API and ICP because we have one of the best clinician of our time. Dr. Sheshad Vissar is joining today. He's a former professor and head of the Department of Endocrinology and Metabolism and Diabetes. Really thank you, sir, for joining today. And we have Dr. Gugan Ramamurthy, the consultant neurologist from Tiruchendur, is joining as a consultant neurologist and a specialist physician for this evening. And we have Dr. Ramachandran is joining today. He is as a postgraduate second year to present this case on acute flaccid paralysis. And we have Dr. Anita is joining as a physician from the Department of Medicine, Vellore Medical College. Really thank you, madam, for joining today. Over to the panelists, the postgraduate to start the presentation and discussion. Thank you.
Thank you, sir. Good evening, one and all. A 41-year-old female resident of Vellore working in Avin Parlor, who is a right-handed person and studied up to 8th standard, presented with chief complaints of abnormal cold sensation on both lower limbs followed by upper limbs since today morning, associated with difficulty in walking.
कोई waiting room में उसको इन कर दो फटाफट. अंदर है ना, इन कर दिया ना. चलो ठीक है सर.
Hello, shall I continue, sir?
Hello? Yeah, please go on. Yeah.
हाँ उसने अचानक से बोला.
You want others to be admitted to the waiting room?
वो इन्हें है ना. ठीक है चलो सब चल रहा है ना. कब लाइव किया था हमने? करीब टाइम क्या हो रहा था? कुछ बोल भी रहे थे क्या ये लोग?
Exicon
मैं बोलता हूँ यार, क्या बोलूँ यार. इसका तो हो गया, ये एपीआई वाले का.
Hello.
बात तो सही है यार, क्या ही बात.
Hello.
मैं बोल देता हूँ. अब जो पहले से है वो तो क्या ही करे.
Hello. Hello. Sir. Hello, sir.
Chandran.
Sir.
Yeah.
Shall I continue, sir?
Yeah, please proceed.
A 41-year-old female resident of Vellore working in Avin Parlor, who is a right-handed person and studied up to 8th standard, presented with chief complaints of abnormal cold sensation on both lower limbs followed by upper limbs since today morning, associated with difficulty in walking and difficulty in using both upper limbs. History of presenting illness. Patient was apparently normal one day back, after which she developed history of abnormal cold sensation in both legs up to knee, followed by both hands up to elbow. History of difficulty in using both lower limbs due to weakness of both lower limbs since morning, in the form of difficulty in getting up from bed, difficulty in walking, as the patient feels her legs are flabby. History of difficulty in climbing stairs, not associated with buckling of knees and falls. Then by evening, patient noticed difficulty in using both upper limbs due to weakness of both upper limbs in the form of difficulty in combing, lifting hand above the head, bringing foot to mouth, using hands for toilet purpose. Then by next day, patient had difficulty in holding on to slippers and difficulty in mixing food, writing, and the patient has been bedridden and needs support for ambulation. History of difficulty in turning in bed side to side. No history of difficulty in holding the neck. No history of thinning of muscles. No history of twitching or fasciculations. No history of diurnal variation of weakness. No history of agonizing pain over the muscles. Able to feel clots on the body. Able to appreciate hot and cold temperature. Able to perceive pain sensation. No history of tingling, pin and needle prick sensation. No history of electric shock-like sensation radiating down the spine while flexing the neck. No history of no history of no history of postural giddiness, abnormal sweating, no history of unsteadiness, history of difficulty in negotiating narrow pathways, no history of incoordination in the unsteadiness while washing the face, no history of involuntary movements, no history of memory disturbances, no history of delusion, hallucination, no history of any speech disturbances, able to perceive smell, loss of color vision, no history of drooping of eyelids, no history of no history of double vision, no history of abnormal sensation over the face, able to chew food and able to protrude jaw, no history of facial asymmetry, no history of absence of forehead wrinkling, no history of difficulty in closing the eyes, no history of drooling of saliva, no history of dribbling of food, no history of deviation of angle of mouth, no history of alteration in taste sensation, no history of vertigo, tinnitus, deafness, and hard of hearing, no history of nasal regurgitation, no history of hoarseness of voice, no history of difficulty in shrugging of shoulders, no history of difficulty in turning head from side to side, no history of difficulty to protrude the tongue out, no history of difficulty in rolling the tongue from side to side or marshalling foot back, no history of early morning headache, no history of vomiting, no history of nausea, no history of fever and loose stools, no history of head trauma, no history of neck pain, no history of any recent vaccinations, no history of dog bite, no history of seizures, past history, she had no similar complaints in the past, not a known case of hypertension, diabetes, asthma, epilepsy, and pulmonary tuberculosis, no history of any prolonged drug intake. Personal history, she's a non-smoker and non-alcoholic, tobacco chewing, married since 27 years. She's having 3 children, delivered by normal vaginal delivery. Family history, she had non-consanguineous marriage, no history of similar episodes in her family. Summary, a 41 years old female, right-handed person, presented with acute onset weakness of both lower limbs followed by upper limbs, associated with cold paresthesia involving both upper limb from hand to elbow and both lower limb from legs to knee without cranial nerve and cerebellar involvement. And from history, it's a case of acute bilateral flaccid paralysis involving both upper limb and lower limb, which is proximal followed by distal. And I would like to localize the lesion to spinal nerve roots and peripheral nerves, which can either be due to demyelination or a vascular cause.
Can I ask you something? Hello? Can I interrupt?
Yes, sir.
You said she works in an Arvin parlor. So socioeconomic background, is she from the farming community? Does she work on the fields also? You check into that?
No, sir. She is working in Arvin parlor, which is in our hospital, sir.
No. Is she working on the fields, exposure to agrochemicals? Do you go into
sir.
that?
No, sir.
You need to check that, okay, when a patient presents like this, okay? That's important.
Okay.
A personal history, you mentioned micturition is normal. Anything pertinent in relation to this patient that you inquired about micturition? Urine color?
Sir?
You notice
Sorry,
any
sir?
alteration in urine color? Does it matter in a patient presenting with acute flaccid paralysis?
Yes, sir.
In what way it matters? Can you have a very abnormal urine color along with flaccid paralysis that may lead you to a clinical diagnosis?
Porphyria, sir.
Porphyria, okay. So you need to think about that. You need to inquire. If you don't inquire, you'll never elicit that history, right? Okay. This is the COVID era. You said no vaccination, right? He must have
Yes,
had
sir,
COVID vaccination. When was
Not
the
in the
last dose of COVID vaccine? When was it?
Not in the past 6 months. She's saying
Okay.
that
So
she had
she had not. Okay. So you asked, and the last COVID vaccine was 6 months ago, 6 months or more ago, correct? Is that correct?
Yeah. Yes, sir.
Okay,
Yes, sir.
fine. All right. Dr.
Yes,
Guhan,
sir.
you might want to clarify anything in the history from Dr. Hemachandran.
No, sir, I'm comfortable, sir.
You're comfortable. Okay, fine.
Thank you, sir.
Shall I
Proceed. Yeah, please proceed. Yeah.
Okay. General examination. Patient is conscious, oriented, moderately built and nourished. No pallor, no icterus, no cyanosis, no clubbing, no pedal edema, no generalized lymphadenopathy, no neurocutaneous markers, no peripheral nerve thickenings. Patient's BP was 130/90 millimeters of mercury measured in right upper limb in sitting posture with no postural hypotension. Pulse rate was 90 per minute, regular in rhythm. SpO2 98% under room air. Respiratory rate was 16 per minute. Higher mental functions. Patient is a right-handed person. MMSE score was 30/30. She's conscious. She has a score of 10 for orientation, 3 for registration. Attention and calculation, she gets 5, 3 for registration and recall, and 9 for language. Examination of cranial nerves. Olfactory nerve, able to perceive smell on both sides. Optic nerve, visual acuity normal on both sides. Field of vision, color vision, fundus examination are normal on both sides. Oculomotor, trochlear nerve and abductor nerve examination. Eyes are orthophoric, no ptosis, no squint. Extraocular movements full and free, no nystagmus. Bilateral pupils 3 mm in size. Reacting to light. Both direct and indirect light reflexes. Accommodation reflex normal. Trigeminal nerve, sensory examination intact on both sides. Motor examination intact on both sides. Conjunctival and corneal reflexes present on both sides. Jaw jerk was absent. Facial nerve, motor and sensory component was intact on right and left side. Vestibulocochlear nerve, Rinne's test, air conduction is more than bone conduction on both the ears. Weber's test, it showed no lateralization. Glossopharyngeal and vagus nerve, palatal movements present and equal. Spinal accessory nerve, able to shrug the shoulders and turn against resistance. Hypoglossal nerve, no wasting, fibrillation, deviation, and strength was normal on both.
So with regards to cranial nerve, you say jaw jerk is absent. You made a comment about absent jaw jerk. How do you interpret that? Is that normal or? Hello, can you hear me?
Dr. Hemachandran? Dr. Hemachandran?
I
Dr.
think his
Hemachandran?
connectivity maybe.
Yes, sir.
Hello?
Dr. Hemachandran?
We'll call him, sir.
Yeah. We have a problem with connectivity. Bandwidth.
So ask him to rejoin, sir. I think network issue.
Network problem. Okay.
Okay.
Should we also disconnect and rejoin? Ma?
No need. Sir.
Hello.
Hemachandran?
Hello.
Ah, okay, okay. You can present.
Yes. Slideshow.
Dr. Hemachandran?
Yes, sir.
Sir actually asked a question just before your internet got disconnected. Sir asked about the relevance of absent jaw jerk in this patient.
Okay, sir. So actually, normally, normally a jaw jerk was absent in
Seshadri sir, your mic is muted, sir.
So the point is, if we are able to elicit a jaw jerk, it is abnormal, right? Okay.
yeah, yes,
So,
sir. Yes, sir.
yeah, okay. Normally, the jaw jerk is very difficult to elicit. You can't make out. If you are
Okay.
able to elicit it, it's considered to be brisk, right? Go on.
Okay. Okay, sir. Thank you, sir. Motor system examination. Bulk upper limb measured 10 centimeter above the oliguranon process is 27.5 centimeter on right side, 27 centimeter on left side, 10 centimeters below oliguranon process, 27 centimeter on right side and 26 centimeter on left side. Lower limb 18 centimeter measured 18 centimeter above the tibial tuberosity, which is 41.5 centimeter on right side and 41 centimeter on left side. 10 centimeter below the tibial tuberosity, it was 32 centimeter on right side and 31 centimeter on left side. Tone was normal in upper and lower limbs. Patellar and ankle clonus absent. Power shoulder joint flexion, extension, adduction, abduction, external rotation and internal rotation was 0/5 on both sides. Elbow joint flexion and extension was
Okay,
0/5.
Initially, you had said the patient felt it to be flaccid, but here you mentioned the tone has to be normal.
Sorry, sir, it was hypotonia. I actually mistakenly typed it as normal.
So all four limbs are hypotonic, correct?
Yeah, yes, sir.
Right. Okay.
Elbow joint flexion and extension power was 0/5 on both sides. Wrist joint radial deviation, ulnar deviation, extension, flexion, supination, pronation was 0/5 on both sides. Hand grip was around 30% on right and left sides. Hip joint power was around 2/5 in flexion, extension, abduction, and adduction. Knee joint in flexion and extension power was around 2/5. Ankle joint power was around 3/5 on plantar flexion, dorsiflexion, inversion, eversion. Reflexes, superficial reflexes, abdominal reflex was absent. Plantar reflexes shows bilateral withdrawal response. Bicep jerk absent on both sides. Tricep jerk, supinator jerk, knee jerk, and ankle jerk was absent on both sides. Cerebellar function tests couldn't be elicited since the patient has weakness. So we have done, the patient has no nystagmus, no titubation, no involuntary movements, and normal speech. Sensory system examination. Touch, pain, temperature, position sense, joint sense, vibration is intact on both sides. Rhombus couldn't be elicited. Tactile localization, 2-point discrimination, stereognosis, graphesthesia was intact on both sides. No signs of meningeal irritation. Spine and cranium examination normal. Autonomic nervous system normal. Other system Nervous system examination, CVS S1, S2 present, no murmur, RS bilateral air entry present, normal vesicular breath sounds present, per abdomen soft, no acromegaly, bowel sounds heard. Shall I proceed? Hello?
Yeah, go on. Is there anything else you want to mention on the physical examination?
Sir?
Is there anything else that you would like to mention on the physical examination? No, you have finished. Yeah, on physical examination. See, this patient, this young lady has, as you said, flaccid paralysis of all four limbs. She's not able to move anything. So one of the important questions can be, does she have a neurological problem, or is it a problem that is not neurological? Can a psychological problem present like this? Acute paralysis, all four limbs not able to move? And if so, how will you distinguish that from a neurological problem? You get my question?
Yes, sir.
Yeah. A conversion reaction, for example. A hysterical conversion reaction. Sometimes patients come with paralysis. Maybe one side, both sides, all four limbs, anything can happen, right? So how do you
Yes.
distinguish that from an organic neurological problem? Is there anything that you look for?
Reflex will be, reflexes are normal. Sir?
Is there any particular sign that you look for to make you understand that the patient is not trying? The patient may say, I'm very weak and can't do anything, but that may be because she's not trying at all. How do you figure out whether the patient is trying or not? You place your hand under one heel and ask the patient to raise the other leg. You know about that?
Sir.
You know what that sign is called?
Yes, sir.
What's it called?
Who was this?
Okay, have
Who
you
was this?
did you do that?
No, sir.
It is worth doing that, okay? Because
Okay.
see, if the patient has an organic problem, okay, she will try. So you can
Okay.
feel the pressure of a heel against your palm. The functional problem, the patient may just lie flaccid, not try at all. Okay. So you should be able to make sure whether the patient is trying or not. Okay. So for that, that particular sign may be useful. Go on.
Okay. A 41-year female with acute onset symmetrical progressive weakness associated with sensory disturbances in the form of cold paresthesia with no antecedent illness. There is no cranial nerve, higher mental function, and cerebellar involvement. I would like to probably consider this a case of acute flaccid paralysis due to Guillain-Barré syndrome, hypokalemic hypokalemic periodic paralysis, thyrotoxic periodic paralysis, HIV in seroconversion phase, sarcoidosis, Lyme lymphoma, and Lyme's disease.
Okay, the moment you say the diagnosis where you have summarized everything, the next thing is the structures localization. You've provided the summary of the examination findings that is involved. So what are the structures involved in this patient?
Root and peripheral nerves, sir. Sir, you are muted, sir.
Root meaning only motor nerve roots or sensory nerve roots or both?
Both, sir.
Objectively, you didn't find any sensory loss, right? The patient had some subjective paresthesia.
Sensory symptoms was there, sir.
Sensory symptoms were there, but objective examination, there was no sensory loss. That's what you presented, right?
Yes, sir. Yes,
All
sir.
modalities of sensation were intact.
Yes, sir.
Correct? Okay.
Yes, sir.
Go on, proceed. So I think both sensory and motor nerve roots are involved.
Yes, sir.
Or predominantly motor roots.
Predominantly motor, sir.
Predominantly motor roots. Okay, fine. It is therefore very widespread involvement.
Yes, sir.
What is the upper limit of involvement? Anatomically, what is the upper limit of involvement?
So C5, C5, sir.
Which one? T5.
Yes, sir. C5.
Why do you say that?
Because patient had weakness in both upper limbs also, sir. Flexion, extension, and reflexes bicep jerk, tricep jerk was also absent. So
So
more
that goes up to cervical.
probably upper.
So
Yes, sir.
why D4, D5? Huh? It'll go up to the cervical enlargement of the cord, right?
C4, sir.
C4, okay. So why do you say C2, 3, and 4 are spared? You're saying C5 down, there is a problem.
Yes, sir.
So how do you say 2, 3, and 4 are spared? What muscles are spared for you to come to that conclusion?
So C1 supplies C1, C2 doesn't have a
Oh, no,
motor.
C1, no, only C1 doesn't have a motor component. Am I right, Dr. Gohan?
Yes, sir.
C1 is
Very
sensory.
much, sir.
C2 has a motor component.
Sir is asking you to test for the neck power.
Do you know the myotomes? Same way as you have dermatome, you have myotomes. You understand that, right, Dr. Hemachandran? So C2 root predominantly supplies what muscle? And 3 and 4 supply which muscle? Which is the major muscle in the neck, anterior part of the neck part? Very powerful muscle. Helps you to turn the head from side to side. Which one is that? Hello?
Dr. Hemachandran, I think he dropped.
He dropped out again. Okay, again, bandwidth problem. Hey, Dr. Anita also is not there. She has also dropped out, I think.
Dr. Anita is actually here, sir. It shows in the.
She is there. Huh?
Yes,
Okay.
sir. Hemachandran has joined back.
Sir. He's trying to join, sir.
Sorry for the interruption. Network issue.
Hello? He is there.
He's joined back again, sir.
Yeah, join.
Hello, sir.
Yeah. Yeah, we were discussing myotomes, right?
Hello, sir.
C2 root supplies predominantly which muscle?
Yeah, yes, sir.
Are you aware?
Yes, sir. Yes, sir.
Hemachandra
sir.
sir has a question actually. C2 supplies which muscle? You know?
No, ma'am. Hello.
C3 and 4 innervate which muscle? Predominantly. You're not there yet. Yeah.
Hello.
Can you hear us, Dr. Hemachandra?
It's in
Dr. Hemachandran?
Should we turn the video off? Then might be better, you think?
He is actually switched off his video, sir.
Hello.
Dr. Hemachandran?
Hello, sir, can you tell them to be connect with the Wi-Fi?
Dr. Anita?
So I will tell him. I will tell him, sir. Okay.
Hello.
So I will call and tell him to join with the Wi-Fi.
Hello.
Hemachandran, is your network fine now?
Hello, sir. I will call him to join, sir, again. Actually, some issues with his network, I think.
Okay. Okay.
I will call him to join with the Wi-Fi.
Wi-Fi and have a mobile hotspot as backup. I think.
Hello.
Ah,
Hello.
yeah. I can hear you.
Yeah. Sorry, sir. Sorry for that.
No problem. I think network is a problem. You have
Yes, sir.
mobile hotspot as backup. We are using Wi-Fi so that if one goes off, the other will be there. Okay.
Okay, sir.
Okay.
Yes.
Yeah, go on. Proceed. So we were talking about C2 and sternum aside 3, 4, and which muscle was it? C3, C4.
C2 rectus capitis. Hello.
Hello.
Hello. Rectus capitis
I think he's trying to get his presentation.
Hello. Hello, sir.
Hemachandran, are you able to hear?
Yeah, yes, sir. Hello.
Yes, please proceed.
Hello, sir. Yes, sir. C2 rectus capitis and C2 muscle, C2 supplies rectus capitis anterior and posterior, sir. Anterior and
Seshadri sir, your mic is muted, sir.
So 3 and 4 mainly trapezius, right? Yes,
yes,
mainly trapezius, right?
So what is the movement that C2 does? What is the movement that C3 does? And what is the movement that C4 does? The myotomal pattern. What is the weakness that you expect in C2? What is the weakness you expect in C3? And what is the weakness you expect in C4? That is what sir is asking by myotomal pattern. Is it neck or is it shoulder?
yes,
What is the weakness in C2? What is the weakness? Neck. Which movement in neck specifically do you look for C2? C2. Which
next forward flexion. Forward flexion in C2 is
okay. And C3?
C3 extension, neck extensions.
It's more of lateral flexion.
Lateral flexion.
C4.
Sir?
C4.
When you don't know the answer, you shrug your shoulders, right? What?
No.
Okay.
Yes.
All right. C4 does that. Okay. Yeah. Go on. So you feel those movements where what you described in your examination, they were all normal, right? Okay.
Yes, sir.
Yeah, they were all normal. Right? Is there any other reason to believe that those segments are spared? You mentioned something about respiratory rate and oxygen
Yes,
saturation, all that. What's the root value of the diaphragm? Dr. Hemachandran? Yeah. So if those segments are those segments or the root from there are involved, you might expect weakness of the diaphragm, right? So you might find a faster respiratory rate. For the bad, you might find a little desaturation. All right?
Yes.
Yeah. Okay, go on.
Yes, sir.
So that's why you're saying the upper extent is probably C5. All right, go on.
Yes.
You have to tell us why it is not the spinal cord. Why can't it be the spinal cord?
If it is spinal cord, there is a definite sensory level. Here, sensory system was completely normal.
Are there any spinal cord lesions that spare the sensory system?
Sir, sorry. Sir, can you repeat, sir?
Can there be a spinal cord lesion where the sensory system is relatively spared?
No, sir.
No. Okay. So you are very confident that the completely normal sensory examination excludes the spinal cord lesion. Correct?
Yes, sir.
Okay. So then it's not a cord lesion, then you say it could be root. Why cannot
Yes, sir.
this be peripheral nerve?
In peripheral neuropathy, there will be a length dependent pattern, length dependent
Okay.
distribution will be there.
Right.
So, yes, sir.
So most
This-
commonly, lower limbs
muscle
are
are more
okay affected first, and then upper limbs much later.
commonly.
Right. Okay.
Yes, sir.
Okay. Supposing we say okay, not at the peripheral nerve, but maybe at the myoneural junction. Can it be a problem there? Myoneural junction. Can you get flaccid paralysis?
Myoneural.
Hemachandran, your network is very poor and your voice is breaking completely.
Yeah.
Not able to understand actually. Is there any other network that you can join to?
Hemachandran, you just get
No,
help
sir.
from other PGs.
Hemachandran?
His slides are there.
Yes, he's still in the meeting as well, sir.
Yeah, he's still in the meeting. But his audio is muted. Can you unmute? Hello, you are muted.
So I called him, sir. So maybe because of that he muted.
Oh, okay, okay.
So extremely sorry, sir. Actually, he's having some
Oh,
network
that's okay. Yeah.
problems.
These things happen, you know.
So until then, Gun sir, if you want, you can discuss a few points. Sir.
Yeah, sure. Actually, I'll do that.
Yeah.
I'll just tell until he comes back, let Hemachandran sort his network issue completely. Let him this time. I'll just tell a few points with regards to peripheral neuropathy or
Dr. Guhan, why don't you
yes, sir.
proceed? Yeah.
Do that
What
until
you would consider in this patient as
yes.
yeah.
So first, when a patient presents with my approach in a patient presenting with weakness would be that when a patient presents with the weakness and the sensory involvement, here the sensory involvement is subjective and objective. There is no evidence. There is only weakness that is evident here, and here the weakness started off with lower limb proximal portion extending to the proximal upper limb, then to the distal portion, and that was rapid in onset. Though it was not within a minute or an hour, it extended beyond 12 hours or up to a day, as in this case the history. So the first thing that I would like to think in this patient is that is the lesion UMN or LMN. So when the lesion is UMN or LMN, the difference primarily rests on the tone, the reflexes that includes both deep tendon and the superficial reflexes, and certain patterns of sensory involvement. So if this patient is going to have an exaggerated reflex with an extensor plantar or a Hoffman or a Wartenberg, then that would put the lesion in the UMN. But that's usually not the case when the patient presents acutely. You will have where the patient is in spinal shock and the plantars are mute, and you might not be able to elicit a Hoffman or a Wartenberg. At that point, there are certain other parameters that we can take into account. That is especially the patterns of involvement. If there is hemi-involvement more on one side than the other side, then that would favor like hemiplegia. That's unlikely to be a peripheral event. It's usually a central event. And sensory dissociation, where there is pain and temperature lost on one side, and there is large fiber involved, that is the vibration and joint position involved on the other side, then that again is usually favors human type. So these are certain human findings that you will have to take into account. And you say either it's human type or an element type. Once you have said that it's human or an element type, the next thing is that once you've come to a conclusion that it's element, then the next point would be that is it a focal involvement or is it a peripheral involvement? So for example, if there is going to be a focal involvement like this, a patient has a right hand weakness. And once there is a right hand weakness, say for example, an abductor pollicis brevis, and this can be due to, in the right side, it can be due to a left motor cortex involvement or a left corticospinal tract involvement, or the spinal corticospinal tract involvement on the right side, or it can be a anterior horn cell, C8 anterior horn cell, or a C8 root, or it can be the lower trunk, or it can be the medial cord, or it can be the median nerve. And with this localization, we will have to add another finding. So if this patient, I would say that if he also has a numbness in the Parmar aspect of the second digit, the weakness is in the C8T1 distribution, and you find a numbness in the Parmar aspect of the second digit, then this would take it to the median nerve. So this is the localization and a focal finding. That is the weakness and the sensory loss, does it correspond to a particular nerve or does it correspond to a particular root? So if it is going to be a multiple root, or is it multiple nerves? If it is going to be multiple root involvement, it's usually a plexus, that is a supraclavicular plexus. If it is going to be a multiple nerve involvement, then it is usually going to be a infraclavicular plexus. So these are the things that you need to keep in mind when it is going to be a focal finding. But when you have a generalized finding, the things that you would consider are does this patient have a proximal involvement or a distal involvement, or a proximal and a distal involvement? Does this patient have a sensory finding? Does this patient have a motor finding? Or does this patient have a sensory motor finding? Are the findings symmetric and asymmetric? So these are the things that we commonly look for when this patient has a generalized element type of weakness. So when you, let's take first sensory motor. If you take sensory motor findings in a person and the lesion is proximal, and this is usually asymmetric, then we consider a diabetic lumbosacral radiculoplexus neuropathy or any other cause of the lumbosacral radiculoplexus neuropathy, which otherwise, if not diabetes, would be a radiation or a malignant infiltration. But usually in this case, there will also be involvement of distal part as well. In diabetic is usually proximal portion, especially the thigh. Okay, and if it's going to be proximal and distal under sensory motor.
Hello, sir. Hello. Hello.
Hello.
Hello, sir.
Yeah, I think it's
Is your network fine now?
Yes, sir. I switched the room, sir. I went to another room. I hope network will be fine now.
Okay.
Dr. Gushan, why don't you go ahead and finish that discussion? Then Kemachisan can join. Yeah.
So if the sensory motor involvement, if the patient has a proximal and distal involvement, then if it is symmetric, then we would think of a radiculoplexoneuropathy, where the typically it's AADP if it is less than 4 weeks. If it is more than 4 weeks, 4 to 8 weeks, it's SIDP. If it's more than 8 weeks, it's CADP. But when it's less than 4 weeks, AADP or AADP mimics. The classical would be AADP, and the AADP mimics would be sarcoid lymphoma or HIV in the seroconversion phase, or Lyme's disease. Especially we differentiate this based on the CSF parameters because the external markers do not always help. The CSF parameter that we look is for the CSF albuminocytological dissociation. And if it is going to be asymmetric, then we actually need to look into the evolution. Because this commonly happens in mononeuritis multiplex, where there is sensory motor one nerve is first involved and then other nerve is second involved. And during the course of the progression, this patient will have proximal and distal sensory involvement asymmetrically. But as the mononeuritis multiplex progresses, eventually this patient will start to have proximal and distal, it will asymmetric will become symmetric, because all nerves are completely involved, and at one point it will become symmetric. So this is actually one clinical finding as well, because if it is a peripheral nerve involvement, it's usually length dependent. For practical purpose, though, other peripheral nerves non-length dependent are there, and which we'll be seeing later on. So if it is usually length dependent, where the sensations are lost as we go farther away from the spinal cord, and the longer the nerve, earlier it is affected. Whereas in spinal cord lesions, this length dependence is not there. There is a definite level below which there is, it's the same pattern of involvement. The graded sensory loss is not there. Mononeuritis multiplex is like that, where it has it presents like a cervical cord compression, where it can involve all nerves in the lower limbs and upper limbs, and can have a cervical myelopathy pattern of sensory involvement as well. That's with regards to the proximal and distal sensory motor asymmetric. Now coming only to the distal part, if this patient is going to have only the distal part sensory motor involvement, then it is a classical polyneuropathy. Okay, what is the distal symmetric polyneuropathy? And the next thing, we have completed the sensory motor part. Now coming to the motor part, if this patient only has a motor finding and it's going to be a proximal. So proximal, it's usually symmetric involvement in motor. And if it is going to be a symmetric involvement, it is usually a myopathy. The other differential would be a spinomuscular atrophy or ALS variants, where like a bibrachial amyotropic diplegia or a crural diplegia, where proximal involvements are there. So this is for proximal pure motor. Now proximal and distal pure motor would be the extension of the spinomuscular atrophy or the progressive muscular atrophy, which is the LMN variant of the motor neuron disease. And these patients can also have infectious causes that involves the anterior horn cell, paraneoplastic causes that involves the anterior horn cell. At this point, I would like to make a point that the one differential that we would like to use, or one clinical point that we would use, is that if the patient has an asymmetric distal motor involvement, then it is, and it progresses to a motor neuron disease, it is ALS. But if it is a symmetric, rapidly progressive pattern that mimics the findings of an ALS, then we need to look into paraneoplastic processes and infectious processes of ALS. So this is one case where ALS can be symmetric with proximal and distal involvement. That is when it is an infectious cause, when it is a paraneoplastic cause. And if it is asymmetric, I have already mentioned, it is ALS. ALS, the classical ALS, usually has a asymmetric distal onset, progresses to involve the proximal muscles, and then goes on to the other limb. And now coming to the distal motor involvement, this is usually the pure, that is the hereditary motor neuropathy, especially the pure motor variant, or it can be multifocal motor neuropathy when it is symmetric. Especially multifocal motor neuropathy, it starts off as asymmetric and finally it can spread on to the other limb as well. Asymmetric is multifocal motor neuropathy at onset, and it can be Hirayama disease as well. Hirayama disease is where there is anterior horn cell involvement due to the dural displacement. Now we have completed sensory motor, we have seen motor. Now coming to the pure sensory part. When the patient has symmetric proximal and distal involvement, it is usually a spinal cord pathology, proximal and distal in both lower limbs or all four limbs, spinal pathology, especially involving the dorsal columns. If it is asymmetric, it is sensory neuronopathy. If it is distal predominant, it is large fiber neuropathy, or it could be a polyneuropathy as well, again, without the motor involvement. So this, for answering all these questions, that is it proximal and distal, or is it sensory motor, is it motor, is it sensory? This will actually help us diagnose a generalized weakness. If it is focal weakness, again, going to that point, we need to look, is it a nerve pattern or is it a muscle, is it a root pattern? So if I actually go into the details of each root, it might take even more time. Like in simple terms, if it's going to be a C5 root, then we look into the rhomboids, we look into the supraspinatus, infraspinatus, deltoid, biceps. C6 would be deltoid, biceps, brachioradialis, some pronator teres component as well. And the C7 would be more of the triceps, importantly in C6, C7. And in C7, you also look into the finger, that is the long flexors and long extensor, the extensor digitorum. C8, T1 is predominantly the intrinsic muscles of the hand. So you look into the patterns. That's actually one question that I also wanted to ask, because S1 root involves the hip extension, knee flexion, and plantar flexion. So this is carried out by S1. So when you are actually localizing the root in this patient, that is, you actually localize it to the root, and it's actually a polyradicular neuropathy. But in this patient, you have actually when you have localized into the roots almost have equal power. Like for example, if it's going to be a lower limb, the S1 root would be hip extensors, the knee flexors, and the plantar flexors. In this case, actually, Dr. Hemachandran, if I'm not wrong, I remember the power in the plantar flexors to be 3.
Yes, sir.
And the hip extensor is 2, or is it 1?
2, sir.
2, okay. 2, 1 MRC variation is acceptable. Usually, if there is a radicular pattern of involvement, the same radical muscles, say for example, in this case, come to the lower limb, you look for the same radical with different nerves. That is, the hip adduction and knee extension is by L3, L4, but different nerves. Then hip adduction is going to be an obturator nerve, and knee extension is going to be a femoral nerve. So if you actually look into the lower limb, the extension is 2 and adduction is 2. So it follows a radicular pattern. Hip extension is 2, knee flexion is 2, and plantar flexion is 3, though one variation in MRC is possible. More than one variation, usually 2 is not possible. At that point, we would like to either re-examine or we need to consider other differentials as well.
Okay, sir.
Okay, Seshadri sir, with that I complete the short discussion, sir.
Yeah. Now you proceed and tell us, you had put up your differential diagnosis there,
Yes, sir.
right? At the end of your evaluation.
Yes, sir.
You tell us what investigations are likely to lead you to a clear diagnosis.
CSF analysis, sir.
Okay. Was the CSF done in this patient?
Yes, sir. CSF was done.
Okay.
Yes, sir.
What are the findings?
It shows albuminocytological dissociation.
That
Sir, sorry.
Protein of
Sir, sorry. Sir.
CSF protein was how much? CSF protein.
Yes, sir.
How much was it? How many milligram per deciliter? Yeah, the value?
Yeah, yes, sir. CSF protein was above 120, sir. 120 milligrams per deciliter.
More than 120, all right.
Cells were less than 30.
Okay, fine. So that is in favor of what? Elevated protein and
It is demyelination, sir. Acute demyelination. It is in favor of demyelination.
All right.
Possibly Guillain-Barré syndrome.
All right. Okay. So that is in favor of that.
Yes, sir.
Your other diagnosis, if you want to exclude, what would you do? What are the salient other tests that you would like to do?
For hypokalemic periodic paralysis, potassium was normal, sir.
All right. Okay.
TFT was taken. It was also normal. It doesn't show any hyperthyroid.
All right.
Hyperthyroidism.
Okay.
In HIV, there is no external markers of HIV.
All right.
So we can rule out that. Also, sarcoidosis. For sarcoidosis, also there is no external markers are there.
Maybe it occurs in the seroconversion phase. You will not have immunocompromised state at that point.
Correct. Yeah. You may not have immunocompromised. The patient may not have any other clinical symptoms, but the neurological problem. Right?
Okay.
Okay.
Yes.
You mentioned sarcoid lymphoma, Lyme disease.
Yes, sir.
The usual neurologic disorder due to sarcoid is what? Sarcoid causing a neurological problem. What is the common neurological problems associated with sarcoid? And what is the anatomical site of involvement?
Neurosarcoidosis.
Neurosarcoidosis.
Neurosarcoidosis, site of involvement was in peripheral nerves. Peripheral nerves and spinal cord, sir.
Yeah, spinal cord involvement can occur. But probably the most common neurological problems that occur with sarcoid occur at the level of the hypothalamus, right?
Yes, sir.
Hypothalamus and pituitary. Okay.
Okay.
That is probably a bit more common than involvement of spinal cord or a peripheral. Even though it can happen, that is rare. All right. Okay. Are you aware of any publications on sarcoidosis involving the nervous system from India? Or Hemachandran?
No, sir.
Well, I think you need to look up. Okay, there are.
Okay.
I think from the institute there are, right, Dr. Guhan?
Yes, sir.
Yeah. So maybe you can give them the reference to go through. Okay.
Sure, sir. Definitely, I'll do that.
Yeah. Okay. Sarcoidosis involving the spinal cord has been quite well studied at the Institute of Neurology, Chennai. There is, I think, a fairly large series of cases published from there, right?
Yes,
With
sir.
very good images, very nice images, right? Okay. All right. You mentioned lymphoma and Lyme disease.
Yes, sir.
Lymphoma involving the nervous system, what would be the most common?
Lymphoma, there will be lymph node enlargements will be there in lymphoma on examination.
Yeah.
So history wise, there will be seizures, weight loss.
Yeah, you may have systemic manifestations that are there. Can you have lymphoma affecting only the nervous system? Primary lymphoma of the nervous system
Yes, sir.
is known, right? Okay. But in lymphomas, the common neurological manifestation would be meningeal, right?
Yes,
Commonly, the most common problem will be a meningitis. Okay.
okay, sir.
Yeah, that would be the most common. So, both in leukemias and in lymphoma, common neurological presentation would be with the signs of meningeal irritation, right?
Okay, sir.
Right. Even though focal lesions can occur, they are rare. Peripheral neuropathy can occur with lymphoma as with any other malignancy. Again, rare. More common would be meningeal involvement. Lyme disease you mentioned, right?
Yes. Yes, sir.
What causes Lyme disease? What organism?
Borrelia, sir. Borrelia bugdorferi.
Okay. And how do people get it? What is the mode of transmission?
It is a tick-borne disease, sir.
Tick-borne disease.
Yes, sir.
Has it been reported in India? Lyme disease.
No idea, sir.
I think it has been reported in people who have traveled overseas, right? Am I right, Dr. Guhan?
Yes, sir. Usually only after travel history it has
Yeah.
been reported, sir.
Usually people who travel to Northern America, particularly the eastern coast of North America, okay, New York, New Jersey, that kind of area. People who visit those areas and who camp outside are the ones who are likely to get Lyme disease. So only cases of Lyme disease reported in India have been in people who have returned from overseas. No indigenous case have been reported, okay, as far as I know.
Okay.
Right.
Sir. Okay. Sir.
So the neurological involvement in Lyme disease, can you get this kind of flaccid paralysis?
It involves facial paralysis. Bilateral facial paralysis will be there, and meningeal irritation will be there. Meningitis features will be there.
Okay. So like the other trypanosome, this one also tends to cause meningeal involvement, right? So
Yes,
you can have a meningovascular phase, and
yes,
so signs of meningeal irritation may be there. For bilateral facial paralysis will be reported, right? Okay. Fine, but it would be very unusual in somebody who has been who was born and brought up only in India. Okay, has never traveled overseas. Won't consider that, right?
Okay, sir.
Okay. So how will you manage this? I think the important issue is management, right?
Yes, sir.
You have said it is most probably Guillain-Barré.
Guillain-Barré syndrome, sir. We
Yeah,
have given this patient plasmapheresis. We have given this patient 5 cycles of plasmapheresis.
Yeah.
And then patient's weakness gradually improved by completing fourth cycle of plasmapheresis, sir.
What was the dose of plasmapheresis that you had given, and what was the replacement fluid that you used?
250 ml per kg, 250 ml per kg, or 40 to 50 ml per kg per cycle, sir.
Okay, in this patient, how much was it?
We have given 200 ml per kg, sir. Her weight was
You said she could not stand, right?
yes, sir.
Oh.
Approximately her weight was around 60 kg, sir.
60, okay.
Yes, sir. So we have replaced by 200 mg per kg. Replacement fluid was FFP, sir. Totally 12,000 ml of fluid exchange was plasma exchange was done for her.
Each cycle, how much was it? Was it continuous or was it alternate day that you followed?
Alternate day. We have done it for alternate days, sir.
Okay.
2,400 ml per cycle, sir.
Okay, and how much of FFP had you given?
Eight FFPs for each cycle. We have given around 8 FFPs. So we have given around 40 FFPs for in total.
So what was the quantity of FFP that you had given for each 8? How much ml was it? You've taken out 2,400 ml.
Yes, sir.
How much ml of FFP had you replaced in this patient? And what are the complications you expect for this replacement fluid that you had used?
We have replaced around 2,400 ml per cycle, sir.
In that case, what was the amount of FFP that you had given? What are the complications you expect?
Hypotension, hemolytic transfusion reactions,
Okay.
headache, anaphylaxis.
Okay. Then what else? Did you get any hypocalcemias? Did you get any coagulopathies? Did you have any bleeding diathesis?
No,
Because
sir.
You know why they can occur when you use large amounts of FFP.
Yes, sir.
Do you know why they develop hypocalcemia? How do they collect blood for transfusion from a donor? Collect it into what?
Trisodium citrate.
Citrate, okay.
Yes, sir.
So what happens when large amounts of citrate are infused into a patient?
Calcium will be absorbed.
Okay. So
That will
ionized
be-
calcium will go down. Okay.
Yes.
So calcium will be complex with citrate, which does not dissociate. So we'll have lowering of the ionized center. That's what Dr. Guan wants to know. When you use large amounts of FFP for plasma exchange, did the patient experience any metabolic problem due to hypocalcemia?
No, sir.
And why would they develop coagulation problem?
Sir?
He also asked about coagulation problem. Coagulopathy with large amounts of FFP.
Because it has a FFP has a procoagulants and antifibrinolytic factors. Hello.
Ah,
FFP has a procoagulants and antifibrinolytic factors. So it can cause acute bleeding if we transfuse FFP.
all right. So the moral of the story is you have to be very careful when you use FFP and plasma exchange. You have to be very careful.
Okay,
Can the patient recover without all this? Are there specific indications for using this modality of treatment? Or every patient with Guillain-Barré should be treated with plasma pheresis and FFP?
No, sir. We can also use IVIG, intravenous immunoglobulins.
Okay, intravenous immunoglobulin has been used.
Yes, sir.
Okay, what is the funda? Why do you use it? What is the basis?
Rapid progression of weakness within 48 hours, and autonomic dysfunction, severe weakness at the time of onset. These are all indications for immediate IVIG or plasma pheresis in case of GPS.
Okay, so the main indication is very rapid progression and fear of respiratory paralysis.
Yes,
Is
sir.
that correct, Dr. Guan?
yes, sir. So when the
Yes.
patient has progression of the illness, until the patient reaches a nadir, we can administer.
Correct. So if you find that the patient has progressed at a certain level and has stopped progressing and vitals are stable, then there is a role for waiting and watching. Okay. So
Okay.
not everybody needs plasmapheresis. Okay.
Okay, sir.
All right. Okay. But what is the biological basis of using these modalities of treatment? What does plasmapheresis do? And what does IV immunoglobulin do? How do they work?
It prevents rapid destruction of nerves by the autoantibodies.
Okay, basically you want to mop up the antibodies or you want to get the antibodies out, right? When you do plasmapheresis and use FFP, you're basically removing patient's plasma and replacing it with donor plasma. So you are basically trying to remove circulating antibody. When you use IVIG, what do you do? When you use IV immunoglobulin,
Yes, sir.
you are trying to capture the circulating antibodies and prevent them from acting with the tissue that they are likely to damage, right? That's a basic principle behind IVIG. How much IVIG do you use?
2
How many
grams per
grams? Pardon?
2 grams per kg over 5 days, sir, or 0.4 mg per kg per day for 5 days.
Any problem can happen with IVIG?
Yeah.
Side effects?
Yes, sir. Headache, chills, myalgia,
Okay.
aseptic meningitis can also occur.
Yeah.
What is the contraindication for IVIG?
What are the contraindications?
Hemachandran?
Yes, sir.
Is there a contraindication for IVIG?
So, any renal failure,
Absolute contraindication.
severe renal dysfunction, IgA deficiency.
IgA deficiency is the absolute contraindication. And what other complication can you expect apart from that? Anaphylaxis. What is the risk of aseptic meningitis?
Yes, sir.
Okay, so there is one other complication, and you avoid it in a patient with a known IgA deficiency. You start
Okay.
with a slow infusion reaction and you look for any allergic reactions, anaphylaxis, and if you don't encounter any, then you can increase the rate of infusion.
So how is the patient doing now?
Yeah, she's fine, sir. She is recovered and
Okay. Able to walk. She's able to walk around.
She's able to walk without any support, sir. Without any ambulatory support, she's able to walk now.
She never had any bladder involvement, right?
She didn't have any bladder involvement, sir.
So you're aware of Asbury criteria, or the new other one is Brighton's criteria?
Yeah, yes, sir.
What does Asbury criteria say? What are the levels in Brighton's criteria?
Three levels are there, sir, in Brighton criteria.
Okay.
Level 1, clinical evidence, bilateral symmetrical paralysis.
Which level has a higher certainty, level 1 or level 3?
Level 1, sir.
Okay. And Asbury's criteria?
No idea, sir.
Okay, look up the Asbury's criteria. That was the previous criteria that was used in Harrison prior to the Brighton's criteria, which actually tells you what are the essential criteria, and what are the red flag signs, and what, if present, is not a GBS. That's related to SIRS questions, because if there is a bladder involvement, it is not likely to be the GBS.
Okay, sir.
And if a patient related to SIRS question, again, if a patient presents to you with GBS with rapidly progressive symptoms like this patient, and the attender comes and asks to you, what is the prognosis? How do you prognosticate a GBS patient? What is modified Erasmus Guillain-Barré outcome score? MEGOS.
No idea, sir.
So just look into that. It's based on age. It's based on the prior occurrence of diarrhea, or and the sum score of MRS. Actually, look into the sum score of MRS. You put that into the calculator, and it has a graph which will tell you what is the chance that this patient will go into ventilator, and what is the chance this patient will be ambulant at the end of 3 months and 6 months.
Okay, sir.
Okay.
Okay, sir.
I think we have more or less covered everything, right?
Yes, sir.
Yeah. Is there any other point for discussion, or shall we call it a day?
Dr. Anita? Dr.
Okay,
Anita?
I think, yeah.
Saravanan?
So,
Seshadri sir is asking.
Hello.
Hello,
So,
sir.
Yeah, I think we have come to the end of the discussion.
Yes, sir.
Discuss, therapy, complications of therapy, all that have been
Yes, sir.
discussed.
Finished, we
So-
can wind up.
Yeah,
Dr.
okay.
Saravanan, sir.
Yeah.
Dr. Saravanan, sir. Okay, sir. We can finish. Thank you so much, sir, for the excellent discussion. Dr. Seshadri, sir, and Gugan, sir, for the extensive discussion about the approach to acute flaccid paralysis. And extremely sorry for the inconvenience in between interruption of the network connectivity, sir.
Thank you very much. We enjoyed the session
Yes,
as
sir.
much as Dr. Hemachandran did. Thank you. Thank you.
I
Thank
thank
you.
the
Thank you.
organizers for the opportunity that is given to me. And before, again, I would like to conclude by telling few references that is very helpful in peripheral neuropathy.
Okay.
One thing that is a must read for all residents when it comes to peripheral neuropathy is 2020 Continuum. There is a Continuum is actually a periodical that's published every 2 months on one particular topic, like a peripheral neuropathy or an ataxia. And there is one edition on peripheral neuropathy in which the first chapter is an approach to a peripheral neuropathy patient. It is a wonderful chapter which covers everything on peripheral neuropathy. You cannot find any other chapter that's better than that. It summarizes everything for you under one go. Because peripheral neuropathy, usually when I joined my residency, we'll have to search every book. That is, we go through De Jong, we go through Brezis, we go through Jose Biller, which you obviously have to go through again, but this summarizes all the points for you.
Okay, sir. So possible, you can text me the reference, sir.
Yeah,
Okay.
sure.
Last time sir was mentioning
Yeah.
about braces. Yeah, he was talking about braces also last time.
Braces, and especially in Braces, the myotomal distribution is again excellently given in Paul Braces.
Yeah.
And there is also De Jong, which obviously tells the examination points, especially with regards to sensory examination, motor examination, which is all found in De Jong. And finally, approach book is the practical neurology Joe Spiller, where you have an approach to weakness or approach to a sensory disturbance. These 3 books will summarize right from examination to localization. And especially for peripheral neuropathy, Continuum that was published on peripheral neuropathy in 2020.
Okay, sir. Definitely, sir.
Thank you very much for the opportunity.
Thank you.
Thank
For the organizers.
Thank you very
Thank you.
much. And good night.
Thank you so much, sir.
Thank you, Seshadri.
Actually,
you.
the next session will be the last session for our API Vellore chapter concerns for Government Vellore Medical College. So thank you so much, sir. for
Thank you,
extensive-
Dr. Anita, Dr. Sheshadri sir, and Dr. Gugan. Thank you, sir.
Thank you.
Thank you.
Thank
Good
you,
night.
Seshadri
Thank you
sir.
very much.
Thank you,
Thank you.
Seshadri sir.
Bye.
Good night, sir.
Good night.